start off just general CHF. What is the expected progression of CHF? What can our folks tell patients to expect, particularly if they are compliant with their medications versus if they're not?
So again, let's remember the underlying problem in patients with congestive heart failure is an increased pressure within the heart that is leading to fluid into the lungs, causing shortness of breath, or fluid in the legs, causing the edema. So fluid restriction is going to be important in order to try to maintain that pressure within the heart in the low end. And the recommendation that I usually tell to my patients is just drink the amount of water that is needed for you so you are not thirsty. But there are recommendations of drinking 10 bottles of water a day. Well, guess what? If you have congestive heart failure, that doesn't apply to you. So you should be drinking only the water that is needed so you don't feel that you are uncomfortably thirsty. So that's one simple recommendation. The salt intake is another important recommendation. Staying away from salt, salty products like canned foods, canned meats, or chips in the Mexican restaurants, or adding salt. You have to stay away from it. If you do the fluid restriction and the salt restriction, then it's an issue of being in the right medications to preserve your heart function as much as possible. You may need a diuretic if in spite of your fluid restriction and salt restriction, you're still retaining fluid. So having a diuretic could significantly help your symptoms, and many patients with systolic heart failure will need a diuretic as patients with diastolic heart failure. And then there will be the different medications that are meant to protect the heart muscle and to prevent it from progressing into getting any weaker. So I can tell you that if you have congestive heart failure and you decide not to do salt restriction and fluid restrictions, chances are you're going to be bouncing back to the hospital. So if you do the salt restriction and the fluid restriction, then the next step is, are you in the appropriate, do you need a diuretic in spite of that? If the answer is yes, you're going to be looking at daily weight. You're going to be looking at JVP. You're going to be looking at the edema and make a decision. If somebody is gaining more than 3 pounds in a day, this is not meal, this is not food, this is fluid retention. Especially in patients with chronic congestive heart failure, the daily weight may be very helpful, and you may have to increase the dose of the diuretics in the short term. Remember, if there is an acute weight gain, then you need to remove fluid and you're going to need more diuretics. Increasing the ACE inhibitor and the beta blocker is going to be important for the long term, but it's not going to make a big difference in the short term when there is fluid retention. You will need diuretics for that. And then following, as I said before, the use of a beta blocker and ACE inhibitor. Remember, you're given this to protect the heart muscle, not to treat hypertension. But if the patient happens to be hypertensive, then you may want to increase that so you don't deal with an afterload increase, an increased blood pressure that the weak heart muscle has to face. In somebody with systolic heart failure, you should be happy with a systolic blood pressure of 100. 90 to 100, as far as they are not dizzy or lightheaded from it. You should push it to that value. If somebody with systolic heart failure has a systolic blood pressure of 115, that's a perfectly fine value to go up slowly in the beta blocker or the ACE inhibitor. Remember, you're not giving this for high blood pressure, you're giving this to protect the heart muscle. And in the case of ACE inhibitor and beta blockers, both, the higher the medication you give, the greater benefit the patients have in the long term. Compliance with lifestyle changes, dietary changes, and medications will be key to stay out of the hospital.
Since our job is primarily to keep patients who have already demonstrated that they are at risk for being admitted by being admitted, our job is to keep them out of the hospital. What do you see as the keys to helping them succeed, assuming that they actually want to succeed?
So daily weight, monitoring the weight is key. Giving this continuous education about the fluid restriction, checking every day how much they are taking, checking their diet, checking what is it that they're eating, avoiding high sodium content, and making sure that they are taking their medications properly. Red flags would be if you're certain that they are taking the diuretic and they continue to gain weight, there is the possibility that they may need IV diuretics. And there are some clinics where they can go as an outpatient and get a couple of IV shots, or that could also happen in an emergency department setting. You want to avoid that, and you may want to wait. I mean, remember, patients don't die because of the lower extremity edema. More alarming symptoms are PND or orthopnea, if they are being short of breath and they cannot lie flat on the bed, so then they may need to consider being evaluated in an emergency department. But for edema, you could titrate the medications most of the time and wait in the outpatient setting, particularly if you know the renal function. If you know that their kidney function is appropriate, you can go up in the diuretics. You could be as aggressive as 80 milligrams twice a day. As a rule of thumb, whenever you're using 80 milligrams of Lasix, you're probably going to need some potassium supplementation, so that keep that in mind. Whenever, in my particular case, I like to combine a spironolactone if the renal function is appropriate. So when I'm using more than 40 milligrams of Lasix, I may be adding some spironolactone, because the potassium pills are uncomfortable, they're big, and they don't provide any benefit. So if they're going to be taking a tablet, I'd rather give them a spironolactone that potentially could provide another benefit. But I would say that the daily weight, following the diets, making sure they're taking the pills would be the key. Their symptoms, be aware of orthopnea and PND as red flags, and edema only if they have failed to the oral diuretics. The other exception is when they have renal dysfunction, it becomes difficult to manage, because as you can see, the diuretics are the key to keep them out. And if they have renal dysfunction and the diuretics are not going to be as potent, then it becomes a problem. And you'll see many of these heart failure readmissions are patients with renal failure, that they could not be diuresed properly and they are close to getting to dialysis but are not in dialysis yet. And these are the patients that usually bounce back as readmissions.
Our CHIP medics will frequently see the discharge instructions and see things written on there, and they're not sure how to really relay that information to our paramedics. You did a great job talking to us about what fluid restriction means, and that you think they should gauge the amount of fluid to thirst. So drink to thirst, don't drink to an arbitrary number. And you talked about sodium restriction and how you explain that to patients. How do you explain exercise to tolerance, and what's the benefit of exercise?
So I'll tell you, patients with congestive heart failure, they will develop some sort of weakness in the other muscles because of hypoperfusion and because of lack of activity. They will develop deconditioning. So then the symptom of fatigue becomes difficult to assess. Is this due to heart failure or is this due to deconditioning? So in fact, patients with congestive heart failure qualify for cardiac rehab. One of the reasons to do the cardiac rehab is not that much to help the heart condition. It's just to prevent deconditioning and to prevent, they decrease their metabolism, they gain weight, they become overweight. It's just to keep them active. And it is hard in patients with congestive heart failure to do it. So the general rule is that ideally they should start under a supervised environment. So cardiac rehab will be the best way to do it, because you look at the heart rate response, you look at the blood pressure response, and you could see when his symptoms are really due to decondition or when are they due to congestive heart failure. So a patient who has never been evaluated, by cardiac rehab, and you don't have an objective assessment, the goal is 30 to 45 minutes of aerobic exercise 3 to 4 times a week. But they have to build into it. So they may start with, routine 15 to 20 minutes of walking around in the house and so on. Chances are that by walking a little bit in the house, you're not going to get into florid pulmonary edema. So when you say symptoms tolerated, it becomes hard because you don't know if they are declining because of congestive heart failure or they are declining just because they are deconditioned. It's really difficult to give the advice at home, to be honest. Cardiac rehab will be the safest path to do it, so you could distinguish when the symptoms are due to heart failure and when they are due to deconditioning.
So in general, explain it. It's probably not a real good thing to tell patients. We'll just exercise to tolerance, and then our medics are going to have a hard time explaining that. So the best advice is probably do what they tell you to at cardiac rehab.
So the ideal thing would be that they would go to a cardiac rehab. That would be the ideal scenario. Okay. And I can tell you the benefit of cardiac rehab is tremendous, because patients cannot distinguish if their fatigue are coming from the heart failure and are coming from deconditioning. And the reality is that chances are this is multifactorial.
Yeah.
And there is so much that we can do with the heart. If you can improve the other aspects, the patients will end up feeling better.